opportunity to welcome Robert Alai to the group. I think Robert Alai is no stranger to the group here. Professor Trivedi, you can stay if you'd like, or up to you. So as everyone knows, Professor Alai is a public health physician, a specialist in addiction medicine. He's one of our leaders in the drug and alcohol field in Australia and also internationally. Currently, he's on the Australian National Advisory Council on Alcohol and Drugs. He's also the chair of the National Clinical Research Network Working Group for NCCRED and has a number of other hats, and you can check his CV online if you're interested. I'll keep it brief because we are now already over time, but I just did want to keep us for another few minutes. Thank you, Robert. Over to you.
Thanks, Nadine, and what a fabulous way to start the meeting. A really interesting presentation. I want to start by paying my respects to elders past, present and emerging, and acknowledge that I'm sitting on the Kaurna lands, people of the Kaurna lands today. And as you said, Nadine, chairing the research committee for the NCCRED board, giving them advice, we focused on fellowship grants, seed funding, pilot studies, and advice on how Australia might create a national clinical research network, which is something that I'm particularly keen to see happen. This session is going to focus on pharmacotherapies, and we have multiple speakers. I'm going to take the liberty of the chair, and what I'm going to do is to introduce the speakers, but then do that at the beginning and allow them to run through presentations so that we can maximise the opportunity for discussion at the end. I think the last session showed the wealth of high quality questions that can come from the audience, and I want to maximise the opportunity to do that. Our session is really in two parts today. The first part will be a systematic review presentation, and then we're then going to move into looking at pilot studies and future work for medication for the treatment of methamphetamine use disorders, and a wide variety of medications from lisdexamfetamine, mirtazapine, psilocybin, anesthetic ketamine, and cannabidiol. So a really broad church of different approaches that are being used in different contexts and different settings. Our first speaker today is Mr. Liam Atchison. He's a PhD candidate at NDARC, and also a research officer at St. Vincent's. Liam, I give you the floor to do your presentation. You have 5 minutes, and I'm keeping an eye on you.
Thank you very much for that. Today I will be presenting the results from our systematic review and meta-analysis of pharmacological treatments for methamphetamine withdrawal. And these are our disclosures of interest. So the cessation of methamphetamine elicits a characteristic withdrawal syndrome. And the evidence shows that the ineffective treatment of withdrawal symptoms can lead to high rates of relapse to use and are associated with treatment outcomes. Importantly, however, as we're all aware, there is no evidence-based pharmacotherapy for the management of methamphetamine withdrawal. The last Cochrane review was conducted 12 years ago. And although it found no pharmacotherapy was effective, this information is now out of date and really needs to be updated. So to do this, we asked the question, what is the level of evidence for the efficacy of pharmacological interventions for methamphetamine withdrawal? And we asked this question in terms of 5 domains, and those were discontinuation from treatment, overall mental health functioning, withdrawal symptoms, craving for methamphetamine, and safety of the treatments. To do this, we searched 4 databases from inception until December 2020, with 2 reviewers independently screening and evaluating the studies. We then assessed the risk of bias, as well as the quality of evidence of these studies using the Cochrane Risk of Bias 2 tool and grade rating scales. We then analyzed the data in RevMed. Overall, we found 9 randomized control trials involving 242 participants, which met criteria for this review. However, only 6 of these studies, involving 186 participants, were able to be meta-analyzed. And this was because 3 of the studies were excluded and they did not report on any of our primary outcomes. Medications that were investigated, it's a broad list. People have looked at mirtazapine, modafinil, ibutylast, amanitin, varenicline, and amantadine. Studies were primarily conducted in the USA and Thailand, but they also have been conducted in Australia and Iran. Mean sample size across the studies was only 27 participants, and approximately 88% of the sample was male. We say approximately because one study didn't report a gender breakdown at all. Risk of bias has been a big issue throughout this review, with 6 of the 9 between treatment and placebo in terms of discontinuation rates. However, there was a small effect of amanitin. However, there was a very low quality of evidence to back this up. We found similar results in measures of global state with no overall difference, but amanitin again showing a small effect with a low quality of evidence to support this. We found no difference for any intervention in terms of ameliorating withdrawal symptoms, and no difference in any intervention in terms of craving. Safety was hard to assess as only one study reported the type and number of adverse events. However, that study found no difference between treatment and placebo. Overall, our review has found that no medication is efficacious for the treatment of methamphetamine withdrawal in any domain. The exception to this is amanitin. However, due to the low to very low quality of evidence and the fact that the medication was voluntarily removed from the market in 1999 due to hepatotoxicity by the manufacturer, this is of quite limited clinical utility. We cannot, however, conclusively rule out any medication that has been tried to date. And this is because of the high risk of bias across the studies, and overall low quality of evidence, very low numbers of participants, and serious gender imbalances, which affect the generalizability of the results. Safety has been very poorly addressed in this literature, making assessment of risks and associated benefits impossible. Importantly, 4 trials did not mention any safety outcomes whatsoever. 4 further trials just gave a narrative description of safety, saying that in text there was no difference between treatment and placebo, and only 1 actually gave a quantitative breakdown of safety outcomes. The implications for policy and practice are, of course, limited by the risk of bias, the number of studies, and the lack of harmonization across outcome measures, particularly given the fact that most measures used have not actually been validated for use in methamphetamine using populations. In the last 12 years, since the last Cochrane review, only 5 randomized control trials have been published for methamphetamine withdrawal, and only 2 of those were able to be meta-analyzed. This is despite withdrawal being often the first step in somebody's treatment journey, and it is often seen as an important barrier to people meeting their treatment goals. In conclusion, no medication is efficacious for the treatment of methamphetamine withdrawal, but there is insufficient evidence to rule any out yet. There is a clear need and opportunity for high impact and high quality research, which is well designed, of adequate sample sizes, and includes accurate and detailed safety reporting. Thank you very much.
Thanks very much, Liam, and thanks very much for keeping to time. I'll invite you to stay on for the panel discussion at the end, where we can deal with the questions that have been asked. And I just remind people to put your questions through the Q&A section rather than chat, because it's easier for me to monitor. So we have now 4 speakers. The first of this is Dr. Krista Seefried, who is the Clinical Research Lead and Deputy Director at NCCRED. She'll be followed by Associate Professor Rebecca McKetton from NDARC, followed by Dr. Jonathan Brett from Pharmacology Unit at St. Vincent's, and finally Dr. Gil Betty from Origin. So could I ask you, Krista, to share your screen and do your presentation? Thank you.
Thank you. Thanks, Robert. So my presentation kicks off the rapid fire session. So this will be a brief presentation, but I'm hoping that I can share with you a little bit about a study that we're currently conducting. So this rapid fire session is on the future of pharmacotherapy clinical trials in Australia. And this particular presentation is the OLAM study. I'm presenting this today on behalf of my colleagues, my study co-investigators who are listed on this slide. I'd like to just echo the previous panelists and discussants on the acknowledgement of country, and I acknowledge that today I'm delivering this talk from the land of the Gadigal people of the Eora Nation, and I recognize the strength and resilience of those people who maintain a continuing connection to the lands and waters, a right and responsibility that was never ceded. I'd like to just mention this disclosures relevant to this study. The OLAM study was funded by NCCRED, and NCCRED receives funding from the Department of Health Australia. A bit of an introduction to the overall rapid fire session, just because this is the first presentation. So Australia has the highest rate of amphetamine or methamphetamine dependence globally, and the number of people in Australia seeking treatment for methamphetamine dependence and use has steadily increased over the past decade. Standard of care involves psychosocial therapy to assist with reducing methamphetamine use, which has demonstrated modest effect, but is often not sustained following cessation of the therapy, was often trialed in earlier contexts where the market was predominantly amphetamine, and can be difficult to access for clients. There is no evidence-based pharmacotherapy for methamphetamine use disorder. We've just heard from Prof. Trivedi and Liam Atchison to that effect. And this presentation aims to provide an overview of current pharmacotherapy trials in Australia for adults seeking to reduce their methamphetamine use. So the OLAM trial is a study looking at people who are dependent on methamphetamine and the acute withdrawal phase. So this slide actually repeats a lot of what Liam just had to say about methamphetamine withdrawal. So stimulant withdrawal does result in a characteristic withdrawal syndrome, and untreated symptoms are a barrier to achieving lasting remission. Earlier abstinence can predict long-term treatment outcomes and transition to ongoing treatment and improved health and welfare. Acute methamphetamine withdrawal can result from a dopaminergic dysfunction related to chronic exposure to high-dose amphetamines. And medications to stabilize dopamine neurotransmission may relieve the symptoms of the acute withdrawal syndrome. This study in particular is looking at an agonist-style treatment and using lisdexamfetamine, which is a pharmacologically inactive prodrug of dexamphetamine, as a candidate for an acute withdrawal symptom amelioration. Lisdexamfetamine, as compared to dexamphetamine, has a slower onset, a lower peak concentration dopamine than dexamphetamine, is a little bit less abuse-liking and more difficult to divert. Our group did conduct a pilot study to demonstrate safety of doses of lisdexamfetamine up to 250 milligrams in a previous population of people who are dependent on methamphetamine. So the OLAM trial is an open label single arm trial of a tapering dose of lisdexamfetamine for acute methamphetamine withdrawal. We're aiming to recruit 15 adults with a methamphetamine use disorder who are admitted to an inpatient withdrawal unit. This is a single center site. This is taking place at St. Vincent's Hospital in Sydney. And these patients are seeking treatment for management of acute methamphetamine withdrawal. They're self-referred through centralized intake, or they're referred by staff who see them in the PANDA unit in the emergency department at St. Vincent's. Day 0 is spent on screening, and then from days 1 through 5, participants receive a study medication. Again, it is open label, there's no comparator arm. This is a safety and feasibility study. So on day 1, the client is aware that they're receiving 250 milligrams of oral lisdexamfetamine, and that dose tapers off by 50 milligrams daily out to day 5. There is an optional washout period for day 6 and 7, and this also facilitates allowing the participant to have a stimulant-free period as they head into a residential rehab, should that be required. They're also followed up at day 14, 21, and 28. I won't go too far into this slide, just to say that the primary outcomes of this study, being a pilot study, are safety and feasibility. And these slides will all be available later on the NCCRED website. I'd like to now hand over to my colleague, Associate Professor Rebecca McKetton from the National Drug and Alcohol Research Centre at the University of New South Wales, to introduce the next trial.
Thank you, Krista. Just let me get my screen up here. Yeah, so today I'm coming to you from the Gambangiri land up on the mid-north coast of New South Wales. And I'm talking to you about the TINA trial, which we're very excited about. This is a phase 3 double-blind randomized placebo-controlled trial of mirtazapine for methamphetamine dependence. I'd like to acknowledge all of my colleagues who are working with me on this trial, particularly our partner agencies, which include Deakin Uni and Barwon Health, Uni of Wollongong and the Illawarra Health District. The Next Step Drug and Alcohol Service in Perth, Biala in Brizzy, and the University of Sydney, Monash Uni and UCLA. So why is it that we're conducting a trial of mirtazapine? Well, you've already heard from Professor Trivedi's talk that there is some evidence for mirtazapine, and that comes from 2 phase 2 trials that have been conducted in the USA. And the first one was conducted quite a while back by Grant Colfax and his colleagues in 2011 on 60 men, predominantly men who have sex with men. And that involved 12 weeks of mirtazapine at 30 milligrams per day. And they found significant reductions in methamphetamine use versus placebo. Now we know we've seen a lot of positive results with different pharmacotherapies, but most of them haven't been replicated. The exciting thing that happened the year before last was that Phil Coffin and his colleagues published a paper replicating that finding in 120 men. And again, predominantly men who have sex with men. They found significantly lower methamphetamine use. It was a modest reduction, but it's statistically significant, and it's probably on par with a lot of other addiction medicines that are available for other substance use. And they also found improvements in depression and reductions in insomnia, which is not surprising given that mirtazapine is an antidepressant drug. And this is exciting because it is already available as a generic drug, so it's quite cheap, and if it was to work on a larger scale, then this could be a scalable and cost-effective pharmacotherapy for meth use. But these trials were done in pretty small samples in the USA, notably all on men, and we really need to confirm the benefits in a broader setting, and we're interested to know whether that would translate if we were to put mirtazapine into a routine clinical care setting in Australia. So we were fortunate enough to win a MRFF grant to answer this question, and we'll be conducting the trial in Geelong, Wollongong, Perth and Brisbane, and hopefully additional sites that we're yet to confirm and bring on board. We'll be looking at whether 12 weeks of mirtazapine, 30 milligrams a day versus placebo can help people reduce their methamphetamine use. We'll be recruiting 340 people dependent on methamphetamine to help us out with the trial. We'll be starting that as soon as we can get going next year, and the recruitment will be running for 2 years. I'd urge you to have a look at our website if you're interested in this trial, and if you're interested in participating too, keep an eye on this trial website. It's www.tinatrial.info. Thank you. I'll be handing over now to Jonathan Brett to hear about his interesting work on psilocybin, I believe.
Thanks, Rebecca. Sharing the screen. Great. So thanks for the invite to talk as well. And I'm also talking to you from Gadigal land, and I'd like to pay my respects to elders past and present. So yeah, talking to you about psychedelic facilitated psychotherapy. So it's psilocybin actually, it's a psychedelic for methamphetamine use disorder.
Hi, Jonathan. Sorry, we can't actually see your slides.
Oh, you can't? Okay. How about now?
Yeah, that's good.
Sorry about that. Yeah. Okay. Great. So yes. So just a little bit about the rationale. So clearly, as we've seen already, there's a large treatment need for people living with methamphetamine use disorder. There is a number of very early studies, phase 1 and some phase 2 studies, looking at using this modality of treatment to treat addictions. It's probably a bit more advanced looking at mood disorders, actually, looking at treatment-resistant depression and all depression. And from those studies, what we've really seen is quite a large and rapid response within a fairly limited time frame. And in the context of the research and this framework, this modality, it appears to be very safe as well. And so there's some hypothesis that actually this modality of treatment, which I'll tell you how it works, is transdiagnostic. So instead of working on a diagnostic level of you're addicted to this or that, or you've got a mood disorder, really it may address some of the underlying factors that those things have in common, such as social disconnection, decreased ability to mentalize, put yourself in someone else's shoes, ruminations or constant sort of thoughts, often negative about yourself and the world, and decreased mental flexibility. So, you know, this modality has not been applied to people with methamphetamine dependence in the past, but there's some rationale that it might actually. However, it's certainly not a magic bullet, and you know, we don't know whether it will work yet because we've not done the study. But certainly, you know, the emphasis on, you know, the psychedelics facilitating psychotherapy, not being a treatment in itself, and that's what makes this modality appealing. Is that, you know, historically psychotherapy and pharmacotherapy has been rather siloed in treatment, and so this might be a nice way to integrate the two of them. But you know, what this is saying is it still requires a lot of hard work on the behalf of the person attempting recovery and the therapist as well. So it's certainly not a magic bullet. But what does it look like? So traditionally, what studies have used is what we call a set and setting protocol, where you have a therapist dyad, so two therapists that are present, and really thinking very carefully about where this is done as well, because we know that the environment people are in and the headspace they're in at the time that they do have a dose of psychedelic really influences their experience. So traditionally what happens is they undergo some sessions, 3 to 4 sessions of psychotherapy that involves building therapeutic alliance with the therapists, setting intentions and enhancing motivation, and then a bit of education about what happens during the dosing day. Then they get 25 milligrams of psilocybin, which is what we call macro dose, so a dose that's hopefully large enough to induce a psychedelic experience, which they then, you know, experience with eye mask and carefully curated soundtracks through earphones. So we encourage people to go within, and the therapy is really non-directive and just supportive during the dosing day. Then they come back and have some more psychotherapy sessions that helps them make sense of their experience in the context of their intentions and plan for the next steps. So what do we aim to do? Well, this is really just a very small pilot study, given it's actually the first in the world to look at it for this indication. And we're aiming to recruit 15 people from within our existing stimulant treatment program. So people with methamphetamine use disorder. We've in this initial study, we've taken a few measures to really minimize the risk of psychosis. So recruiting people who are a little older and who are using less than half the month and have no history or family history of psychosis. So the main things we're looking at really here is safety, feasibility, but we're also looking at a number of other secondary outcomes, efficacy, quality of life, and we're also looking before and after at resting state MRI, particularly looking at the default mode network and a range of biomarkers to look at what might be mediating these effects, if any. And this is just a sort of schematic of the trial itself. And you can see we have 3 screening visits, preparatory psychotherapy, dosing day, and then follow-up for 3 months after that, measuring a range of outcomes. So I'd also like to thank all the other investigators, particularly NCCRED for sponsoring the study, and St. Vincent's Clinic for sponsoring a small component as well. Thank you. I'd like to hand over now to Jill Getty, who's going to talk to you more about, I think, CBD and methamphetamine. Thank you.
Hello, everyone, and thank you for the invitation to attend to speak at this symposium. It's certainly been very interesting. So I'm going to present to you today some information about some studies that we have currently recruiting, the MASCOT and the CALM trials. And I'm at Origin and also the Centre for Youth Mental Health at the University of Melbourne. So first, I'd just like to acknowledge the traditional owners of the land on which we meet and pay my respect to elders past, present and emerging, and to any Aboriginal and Torres Strait Islander people present with us today. Oops, the wrong way. And just in terms of funding and conflicts, this work is funded by seed grants from NCCRED, which we're very grateful for, and we have no conflicts to declare. And I'm presenting on behalf of a range of other investigators who have been very, very much involved in developing these protocols. So we're testing these two medications. These two studies are being run in young people between the ages of 15 and 25 years old. And I just wanted to present a brief rationale for why we're doing that, as it sort of departs from the rest of the data that's been presented today and the rest of the studies. So we know that young adults in Australia have the highest prevalence of methamphetamine use between ages 20 and 29. Ideally, even though people typically don't present for treatment until a little bit later than that, we would be intervening at the earliest possible stage to protect both the developmental trajectory in terms of neurobiology, etc., but also the functional trajectory in the development of things like vocational skills and relationships, etc. So methamphetamine is actually the third most common drug of concern in Victorian youth alcohol and other drug services. So young people do present for care with methamphetamine use at that age. And our model is use of pharmacotherapy to support psychosocial intervention, which is obviously very, very important, particularly in young populations. So I'm not going to go into too much about the detail, but essentially ketamine is a novel candidate for substance use disorders across different substances. It's thought to potentially normalise glutamatergic dysregulation that occurs in substance use disorders and facilitate new learning. And importantly, there's been some very, very strong signals from work with 1 to 2 intravenous infusions of ketamine combined with psychological intervention for alcohol, but also for cocaine use, which obviously is quite similar to methamphetamine. And it has not previously been used in methamphetamine use before. So MASCOT, the first study, is the name for methamphetamine use in young people, sub-anaesthetic ketamine open label trial. We're recruiting 20 people. It's obviously an open label trial. They're all between 15 to 25 years old with moderate to severe methamphetamine use disorder. And our primary aim is just to assess safety and tolerability of 2 ketamine doses subcutaneously, separated by a week in young people with problematic methamphetamine use. And really our key safety concern is around ketamine use itself and whether we see an increase in ketamine use frequency and craving at week 6. And we're also looking at tolerability, just looking at whether people are withdrawing due to adverse medication effects. Because it's an open label trial, we can only get some slight indication of efficacy. So we'll just be looking at preliminary efficacy by measuring methamphetamine use frequency and craving at week 6 compared to baseline. So we're currently recruiting for this study. However, we've had 7 people contact us and none of them have met criteria. So we're basically working with youth AOD treatment services to try and fast track our recruitment for this study. And this is just the schematic. And again, these slides will be available afterwards. So the second study is testing cannabidiol for the same indication. So CBD is a non-intoxicating cannabinoid. It has a range of putative therapeutic effects, including anxiolytic, antipsychotic, and antidepressant effects. It has been shown to reduce methamphetamine self-administration and relapse in a rodent model. However, it did not reduce cocaine use in a subsequent clinical trial, which we theorise might be due to a slightly lower dose than we are using. And there have been no clinical trials for methamphetamine use with CBD. So this study is called Cannabidiol, a novel pharmacotherapy for lowering methamphetamine use, or CALM. very similar outcomes to the previous study. So it's an open label study. We're recruiting 12 young people for this study with mild to severe methamphetamine use disorder. And our main outcomes are safety and tolerability of 8 weeks of maintenance on CBD, initial dose of 800 milligrams titrated to 1,000 milligrams. And the main concern safety-wise is liver function and hepatotoxicity, which has been shown at high doses in a couple of studies. And we're also looking at tolerability in terms of participant withdrawing due to adverse medication effects, which we don't really expect for this study. And we'll also be looking at preliminary efficacy. So for this study, we're finalising ethics and governance and other study initiation activities, but we have the CBD, which is kind of one of the big difficulties with this kind of research at the moment. So we're pleased about that. And this is just the schematic for the study as well. And again, that will be available online. So I'm going to finish there and pass back to Professor Ali for questions. Thank you.
Well, thank you all for your clear and on-time presentations. A really interesting array of presentations that we have for both what's come before and what's coming forward in the future. I'm opening it up for questions now, and I'm pleased to see, Rebecca, that you've shared your link to help us follow and track the progress of your study. So those of you who are interested, you'll be able to find that link in the chat. Can I start by a question that's been posted, wanting to know about why you've chosen such a high dose of CBD and when considering its use in the CALM study? And can you talk to the expected side effects and dropout rates?
So I would, I guess, reframe the question a little bit and think that we need to consider why such low doses of CBD are being sold over the counter, because most of the evidence suggests that CBD at anything lower than the doses that we're using is essentially a placebo. So we've used these 600, 800 and 1,000 milligrams of CBD acutely, not in maintenance, with basically no side effects at all. And people tolerate it very well. The only concern is these couple of studies that we have that are small studies that have shown some signal around liver problems. And so that's something we want to be very cautious about with this population. But in terms of the specific dose for this study, we based it on the animal, on interspecies scaling. And in the animal study, there was an effect at the higher dose, but which is equivalent to 1,000 milligrams, but not an effect at any of the other doses. Now, the cocaine clinical trial, there's actually been a very limited number of good clinical trials for this, for any kind of substance use indication in humans. And the one that has been done so far was negative, and they used 800 milligrams of CBD. So we have a question as to whether or not they might have just missed a therapeutic dose in that study. And the other thing, I guess, just to say about that is that that others, like the psychosis studies, have all used 1,000 milligrams, and the use in children for seizures is actually much higher doses than what we're using. But cost is a problem, so that is something we're definitely acknowledging. It is expensive. So,
okay, thank you. A follow-up question was an idea of the cost for medication.
I would actually need to get back to you on that. From memory, we're paying $6 per 200 milligram tablet, which is obviously very expensive when it gets to 1,000 per day. So that's what 5 times $6, so $30 a day. The problem with CBD more broadly is not just cost, though; it's actual availability. And so, there is not a good pipeline for accessing quality CBD at the moment, and that's something that I think would need to be looked at if we do get a signal here.
Thank you. So there is a question here about particular reasons for exclusion from your pilot. If you could talk to that as well.
Well, a bunch of them, young people, I guess, are harder to engage because their motivation may be more transient. And so they've been in contact, but then by the time we've actually got back to them, they've changed their mind, or the issues in the sort of chaos of life has meant that they're no longer interested in continuing. We've had someone who was on an antipsychotic, which ruled them out. We had someone who was too old for the sample. So it hasn't been one specific thing. It's been a range of different things. But I think we just need to we need to broaden our approach, really.
Okay. Rebecca, running a multi-centre trial across such a diverse area is really an ambitious task. I'm just wondering what your thoughts are about connection opportunities, because doing work like this, I think we've had a track record of doing it with opiates, but with stimulant use disorder treatment, it seems to have been a bit more challenging. So I'm just interested in hearing your thoughts on that.
I have more thoughts at the end of the trial. We have just finished another multi-site trial though. We had 3 sites on board and we were able to do that. And 2 of those 3 sites have come on board this trial. So they've already got capacity and know the procedures. I think that will make it easier. But I have to say from the last trial, and I don't know if this answers your question, but I think the best outcome from that trial, we didn't get any benefit of the pharmacotherapy, but what we did get was just that experience of running a trial and building that capacity in different locations. And I think that's gold. In this trial, we've got 4 sites, and I know some of the people involved are in the audience, like Jeremy. And hopefully we'll be able to get a bit more momentum there, but we're also going to trial a new way of doing things if we can, which is direct to patient dispensing. And that will hopefully allow us to scale up and not be as reliant on having specific geographic sites. And we'll be couriering out the medication to individuals and monitoring them through telehealth. And that's a model we're yet to develop. But if we can do that, that will also ramp up our capacity to run these trials.
Yeah, I think the importance of these innovations is going to be incredibly important, particularly in 2022. Look, there are other questions here, but regrettably, we've already gone over time. So I might need to stop there and hand back to Nadine, because I see that we're due for a break.
Oh, I had a really great question I was going to ask too. Oh, well, just want to thank the panel. Really, really exciting new work happening here, and hopefully leading to larger scale work. And thank all the audience for being with us. We're going to take a short break.